Good morning, good afternoon, good evening, depending on the location from where you are joining us today. Welcome to the Journal of the American College of Cardiology webinar on the burden of cardiovascular diseases and risk in South Asia. We're delighted to have you join us. I'm Dr. George Mensah. I'm Director of the Center for Translational Research and Implementation Science here at the National Heart, Lung, and Blood Institute at NIH. And I'm thrilled to say that we are joined by three distinguished cardiovascular clinician scientists for our discussion today. They are all very well recognized nationally and internationally and have received multiple awards and honors for their work in cardiology or cardiovascular epidemiology. In the interest of time, I will give only one or two sentence introductions so that we save most of the time for the rich dialogue that we're going to have. First, we have Professor Alka Kanaya. She is Professor of Medicine, Epidemiology, and Biostatistics, and she's also a practicing general internist at the University of California, San Francisco, UCSF. Welcome, Professor Kanaya.
Thank you.
Next, we have Professor Chandrashekhar. He is Professor of Medicine at the University of Minnesota, and he's also the current Editor-in-Chief of the JACC Cardiovascular Imaging. Welcome, Professor Chandrashekhar.
Thank you.
And next, we have Professor Srinath Reddy. He's a cardiologist and epidemiologist by training, and is the founding past president of the Public Health Foundation of India, and previously head of cardiology at the All India Institute of Medical Sciences in New Delhi. Welcome, Professor Reddy. Again, we're really delighted to have these distinguished experts help us discuss the burden and trends of cardiovascular disease in South Asia. What we'd like to accomplish by the end of our dialogue is that, one, a real discussion on the leading cardiovascular causes of death and the related risk factors in this region, and the recent trends that we see in the data that we've shared. Second, we'd like to be able to address how the burden and the trends in the data inform regional strategies and actions for cardiovascular disease prevention, for cardiovascular disease treatment, and cardiovascular disease and risk factor control in South Asia. Finally, we also want to be able to highlight the national policy and practice implications for clinical medicine, for public health, and also for cardiovascular research in South Asia. Now, I should also tell you that as background for this webinar, we would like to refer you to the 2022 Global Burden of Cardiovascular Disease report. There was one manuscript and an editorial that was published in JACC in December 2022, and also coming very soon, in fact, next month, the updated data in South Asia and the rest of the world, that would be in the December 2023 JACC issue. So with that as background, let's just dive in. And first, let me begin with you, Srinath. Could you paint for us the big picture about the leading cardiovascular cause of death in South Asia, ischemic heart disease? Please put it within the context of the global burden of disease, and specifically tell us about the experience in India.
Coronary heart disease is now the leading cause of death in India. And virtually every single region of India has recorded in the last 20 years a sharp rise in ischemic heart disease as the cause of death. In fact, if you look at the story of ischemic heart disease among Indians, it started about 70 years ago with very high rates being recorded in comparison with other ethnic groups in Malaya and Uganda. And later on in a number of other countries, virtually whatever the time or climb of migration, Indians who had gone elsewhere were shown to have much higher and earlier onset of coronary artery disease compared to other ethnic groups. But our own story started unfolding in the 90s. And when we started looking at it, initially it appeared that coronary artery disease was not that extensive. But within a period of about 30 years, we have seen it grow very sharply into the leading cause of death. And not only in urban areas, but also in rural areas. And there are many reasons why this is happening, obviously, but certainly it is the leading cause of death, and it has shown a marked rise even within the last 20 years when the records have been compared, both in terms of deaths as well as in terms of disability adjusted life year loss. But the tragedy is that it's fairly premature in comparison with many other countries in terms of the onset of death, or even in the terms of the onset of myocardial infarction. If you look at the Interheart study, the first incident myocardial infarction among people of South Asian origin was 10 years earlier than Western Europe and about 8 years earlier than the United States. And that pattern continues.
That's really, really important. Alka, this is really intriguing, but I suspect that the experience in India is not necessarily uniform across all of South Asia. There seems to be some variation in ischemic heart disease burden between the 5 South Asian countries. What are your thoughts on this variation, and how does this compare to findings in other countries where South Asian immigrants have settled?
Yes. So according to the global burden of disease statistics, it looks like Pakistan had a higher age standardized mortality from ischemic heart disease compared to the other countries in South Asia. And Bangladesh was below India. So Pakistan, Bhutan, India, and then Bangladesh are the way they were ranked. However, if you look at all mortality, not age standardized, you see some variation there as well, with Bangladesh being quite high. So it tells you a little bit about age differences as well, that may be explaining some of that variation, that the age may be much younger in Bangladesh and suffering ischemic heart disease mortality. The experience across several different diaspora countries has also mirrored what this global burden of disease is finding. We have data now from the UK, from Canada, from Spain, and soon coming data from the US that shows similar differences in ischemic heart disease, not necessarily mortality, but in onset of myocardial infarction or coronary disease, where there is differences in patterns, with higher prevalence being found in incidence and prevalence being found in Bangladeshis and Pakistanis compared to Indians. And my thoughts for what may be drivers of these differences are not genetic as much as societal and structural and lifestyle and behavioral and many different social determinants of health that play out in all of these sectors. And so I do think that, even in the US now, we're seeing that there are higher risk factors in Pakistani and Bangladeshi populations compared to Indian populations. All three have higher risk factors than many other US race and ethnic groups, but there's still this variation among South Asians. And it is really important for us who are, doing work in these communities in diaspora settings that we disaggregate the data to be able to have more granular information to really set policies towards improvement.
Excellent. It is really, really important. The issue of data disaggregation and also finding mechanistic studies that can give us better insight as to why these variations exist. Chandra, let me bring you in and ask, what are some of the putative mechanisms that might make South Asians prone to ischemic heart disease and other cardiovascular disease? What is unique about either the origins or the habits or the lifestyles, and how different geographic locations in South Asia manifest different aspects of the excess risk?
Yeah, no, that's a great question, George. It's actually $1 billion question, maybe $2.5 billion question, because the South Asian.
Well, why stop at 2.5 billion as we going up?
Because they probably form 25% of the world's population, right? 20 to 25% of the world's population are in that area. So, despite such an important problem, there have been studies, but not the focused amount of research that's needed to answer this. So essentially, there are two main schools of thought. One, that there is something inherent to people from their genetic or otherwise, and that is probably not the leading theory. The bigger leading theory is they have a certain pattern of risk factors which probably make it more likely that they have more events and more coronary artery disease. And a number of theories come and go, but the more important thing seems to be they have a very high incidence of diabetes, a very high incidence of insulin resistance, metabolic syndrome. And for the same amount of weight, they seem to have a more adverse pattern of body fat distribution, visceral fat. So it probably might be related to the metabolic milieu of these populations. How much of that is diet related? There are certain unique things that they consume, for example, clarified butter or ghee, which was at one time one of the theories thought to mediate this. But it's not exactly clear. These theories come and go, but essentially this seems to be sticking, that they have a higher incidence of metabolic abnormalities. There's, of course, more increase in hypertension now, and that is also playing a part. And there's also a sense that there's less physical activity in these populations. So apart from the genetic background, whatever it is, which has not been established very well, it appears that the metabolic milieu is probably the biggest reason for them to have adverse profiles.
That's very intriguing, and actually your mention and emphasis on the metabolic profile raises one question that I have, and I think I'm going to direct that to Alka. You know, Alka, if you look at the 15 risk factors that were assessed in the 2021 Global Burden of Disease study, high fasting plasma glucose ranked just about midway in terms of the impact on age standardized disability adjusted life years in South Asian countries. Now, I must admit that really surprised me. I had expected fasting plasma glucose to rank way up there, right next to high blood pressure, definitely much higher than it did. So how important is diabetes as a risk for cardiovascular disease in this region? And why is fasting plasma glucose only around the midway?
Yeah, no, that was surprising to me too. But if you dig a little deeper into the data, I think most of those data come from studies that have been done in various states around India primarily, and fasting plasma glucose is generally not assessed. It's usually capillary glucose, and there is no assessment of 2-hour glucose tolerance, because of course that requires a lot more resources to be able to do. So I think we're not getting a full picture in the data that we have. And had we done 2-hour glucose tolerance tests or have fasting plasma glucose done across the region, I think you would see much, much higher prevalence of diabetes and prediabetes. The most recent data comes from India, the INDIAB study that did sample people across most regions of India, finding that about 101 million have diabetes now. That's 11.4% of the Indian population, with another 136 million with prediabetes. I think the important point that gets left behind when we look at a dichotomous disease outcome like diabetes is that the risk actually starts much earlier. than a diagnosis of diabetes. There is not a inflection with diabetes that increases risk. There's a very steady higher risk starting at early stages of pre-diabetes that we are not really measuring well. And the most recent data, which are so compelling, is the diabetes prevention data that come from India itself, that show that lifestyle interventions are not as effective when they are done in people with isolated fasting plasma glucose elevations. So these are people with IFG, that we have to really start upstream a lot more earlier in the pathophysiology of diabetes, starting with impaired glucose tolerance, to really get effective results from lifestyle interventions. And the second take home from many of these studies aggregated together in nice reviews that have just been published recently is that the time that Indians, South Asians, I will extrapolate, even though we mostly have data from India, is that the time in the pre-diabetes years where there is ability to make effective lifestyle change is very, very short, shorter than most other race ethnic groups around the world. Only about 6 years that is spent in pre-diabetes, because there's this acceleration of loss of beta cell function leading to diabetes. So we're compressing the time where we can actually make a difference with lifestyle change, diet, lifestyle, exercise, and we're not catching people early enough. We're catching them too late. So this is just, I think it's just telling of what's going to be an epidemic of diabetes to come. It's already in an epidemic stage, but it's really going to be, it's the harbinger of much more coronary disease and ischemic heart disease in years to come.
And that's really, really concerning, a harbinger of big problems to come. It's really intriguing, the accelerated progression from glucose intolerance to diabetes. And I'm wondering, Chandra, let me ask, are we aware of any studies that have looked at, meaning comparative studies, looking at siblings or families in South Asia and findings when South Asians have migrated west? Anything that we can learn that can shed light on these observations?
Right. Yeah, there have been studies like that. These were probably in the 90s and 2000s mainly. There hasn't been a concerted effort like the Ansel Key study or something which was done for other communities, but I think that's something that might be very revealing. What happens is, especially in some parts of India, there's a huge migration to the west, especially the northwest part of India, the Punjab area. They have a fair amount of migration into UK as well as into Canada. And there have been studies looking at that, and we were involved in one of those in the 90s, which consistently shows that if you look at siblings of residents of Punjab who migrated to West London, you often find a significant deterioration of their risk factor profile once they are acclimatized to the Western diet. And so their cholesterol becomes worse, their insulin resistance becomes worse, their diabetes numbers get worse. And even though their lipoprotein A doesn't change much compared to their LDL worsening, they probably have a more adverse total risk profile. And then, of course, obesity comes into play. So all these things kind of seem to create a much adverse profile. So it looks like when you're in India and having an Indian kind of a diet, you're somewhat restrained in having these bad things happen. I mean, they do happen, but once you are exposed to that underlying substrate and a Western form of diet, which includes higher calories and higher amount of fats and probably higher amount of processed sugars, you end up with a very undesirable profile. And there have been many other studies that replicate the same kind of adverse things happening. So it's probably both the substrate as well as the milieu they enter into, which accounts for accelerated risk.
George, if I may come in on this question.
Yes, please do.
we ourselves have had studies in India where siblings were compared. 3 large industries in different parts of India. About 10 to 15 years ago, the study was done. And where people who had migrated to urban areas because of employment in the industries were compared with their siblings who stayed behind in the villages, in the rural areas. And within 5 years, virtually every single risk factor, whether it was body weight, waist-hip ratio, or the various lipid parameters, insulin resistance, everything measured was up in the people who had urban acculturation, just in a matter of 5 years. So at least that puts paid to the theory that everything is genetic. It is substantially environmentally induced and triggered.
That's really intriguing. Alka, I have to ask you. So now, when you look at South Asians living in America, or South Asians living outside South Asia, what have been the lessons and the learnings, and are they consistent? Do they tell a similar story?
Yeah, actually, our findings in the US stand in contrast to this early findings from the UK in terms of the diaspora differences. We have looked at acculturation in the US. Now, the US South Asian populations has to be considered in a different way than other diaspora countries because of the immigration policies in the US. The people who were allowed to immigrate to the US after 1965 were those who were seeking higher education or who had professional degrees. There was very little family reunification happening then. And so the early waves of migration in the 60s were mostly from North India, and they were highly educated professionals. And you can see that in the census data currently from the 2020 census shows that Asian Indians have the highest rates of education as well as income in the United States compared to any other group because of the immigration standards. So when you look at our population in Masala, which is really sampling people who immigrated after 1965, age groups of 40 to 84 represented in our study, what we find is the 3 patterns of acculturation are quite distinct in that those who have not acculturated to the Western way of living or standards and have stayed very traditional in their South Asian culture have the highest risk factors. Whereas those in the bicultural, the integration pattern, actually have the lowest risk factors. And even those in the assimilation, the ones who've really integrated into the US cultures and norms and beliefs and behaviors, actually have somewhat fewer risk factors than those who have not at all acculturated, which does, stand in contrast with the early studies in the 90s in the UK, because I think there is a big socioeconomic difference in the US South Asians. And so you cannot lump all diaspora countries together because of immigration rules that, may be quite different. So what we are finding is that those who are adopting US beliefs and behaviors because of their higher SES are adopting healthier diets, are exercising more, are not smoking, are drinking some alcohol, and maybe eating some more animal protein, but they relatively have much better cardiometabolic risk profiles than the older generation that is not acculturating.
Certainly really excellent example of why it's so crucial to take a very comprehensive view all the way from policy. I mean, who would have thought that immigration policy could be an epidemiologic selection pressure? But this is really, really very, very important. Srinath, let me come back to you, especially with the examples that you gave. We've touched on population genetics, even some epigenetics and environmental issues, the behavior and lifestyle issues. When you look at the South Asia data, what would you conclude as warranting priority actions? And I ask you that because we know we can't boil the ocean. We have limited resources, but everything we've heard here suggests some urgency So where do we begin? What are the priority actions you would highlight?
Well, and these may differ across the South Asian countries. For example, Bangladesh has very high smoking rates. In India, the smoking rates have come down, much more of an oral tobacco problem now. So there would be variations now. But nevertheless, I think diets matter, physical activity matters, and those are absolutely key taken together for insulin resistance, pre-diabetes and diabetes, and the metabolic syndrome. And therefore, I think those are areas we ought to intervene. And anyway, some of the conventional measures are no longer relevant, like body mass index. We know it's much more of either the waist-hip ratio or the waist-height ratio. But central obesity is a very important feature, visceral adiposity. And that would have low LDL, low levels of HDL and fairly high levels of small dense LDL, which again predisposes to accelerated atherosclerosis. So I think combating the induction of visceral adiposity through unhealthy diets and trying to reduce insulin resistance by improving physical activity are the two key interventions that we ought to undertake, while of course continuing with tobacco control and other interventions as well. And consumption of fresh fruit and vegetables is very low in Indians, despite the claim to be vegetarian. It's a very poor vegetarian diet in terms of composition. And the edible oils too are rather unfortunately now going in the wrong direction, with unhealthy edible oils becoming much more affordable and widely marketed. So there are interventions that need to be impacting on diet and certainly also on physical activity.
I like that. I think you summed it up very nicely. Diets matter, but also the essential message that when we look at the South Asian data, we really need to use the data to inform locally relevant and locally appropriate, depending on which risk factors rise to the top for the particular region. The good news is we have clinical practice guidelines that provide us guidance as to what we do for individual patients. And Chandra, I want to get back to you and especially think about cardiovascular imaging in your wearing another part of your day job for the JACC cardiovascular imaging. The question that I wanted to put to you are, what are some of the clinical practice implications and the challenges for the South Asia region? One of the findings that I thought was really intriguing and of concern is when you look at peripheral arterial disease and the disability adjusted life years for that, that was the most dramatic rise over the period of observation, some 60% or so increase. We have proven effective interventions for prevention, for treatment. We have excellent imaging for screening, for diagnosis. So what are the challenges and what would you want our audience to know from that perspective?
Yeah, so excellent question again. The issue is right now, we know that South Asians are probably one of the highest risk groups among all populations, but there aren't good guidelines for screening, especially imaging-based screening in these populations. And so that makes it difficult. You just have to port the imaging guidelines that you have in the West to these populations. And since their pretest probability of bad things happening is so high, it may be that by the time you use the criteria that you use in the West, you may already have missed the boat, as Alka was pointing out in the context of diabetes. One example may be using coronary artery calcium has had such a bumpy road even in the West, right? The US Preventive Task Force has not endorsed it as much as society guidelines have, and there's a valid reason for that. But if you think in cost effectiveness and the number of people who are having problems, especially when they're having myocardial infarctions at a younger age, like it's not uncommon, and Srinath will attest to this, it's not uncommon for him to see 40-year-olds, 35-year-olds having myocardial infarctions in India. Maybe we need to have a focused kind of a Framingham-like study there, including imaging surrogates, to see what's the best way to do it. There is some data on coronary calcium also from India, but these are opportunistic studies. They are not like systematic studies. The Masala group has some publications on coronary artery calcium in the US among Asians, but these were again, did not reveal anything major. They were, the prevalence, if I remember correctly, Alka, was the same as what was there in Caucasians. But they probably may be implying a higher risk than Caucasians. That study is not known. From the Mensah data, it doesn't look like that, but it might be that some of these imaging markers may be predicting a higher event rate than traditional Framingham-like criteria. But this is still a hypothesis. And so we need a focused effort using imaging surrogates. Of course, looking at plaque is not practical, but looking at coronary artery calcium in a more systematic way may be the way to go. And I'm glad the Masala study is focusing on this to some extent.
Yeah.
Can I
Chandra,
add?
thank you. Yes, please. I was actually going to call on you. Go ahead, Alka. Go ahead.
Yeah, I just want to respond to Chandra. And there is an ongoing population-based study in India that is actually doing coronary artery calcium screening, and that's the CARS study, which is NHLBI funded. And so they are doing both coronary artery calcium scans as well as some echo to look at, precursors of disease and following people. And we're actually partnering with them, comparing the US Masala data to the CARS data. So those data are forthcoming. And, I do agree that the burden of CAC in people without symptoms, again, these are not a clinical population, it's population-based, was similar in the white men in Mensah compared to the South Asian men in Masala. But we are still, we're working on accumulating enough cardiovascular disease events to be able to look at the magnitude of association between CAC and incident events in the South Asians. And CAC is really a downstream risk factor, right? I mean, a lot of people say CAC is, the prevalence of coronary disease already. So we've missed the boat, when we're looking at CAC numbers. Again, you have to look more upstream of that.
Yeah, extremely important. I'm just delighted that you mentioned CARS and Masala. At the National Heart, Lung and Blood Institute, we're really very, very proud of these studies that we fund. And just for all of you in the audience, the South Asian population is one of the priority populations that, from our institute's perspective, exploring cardiovascular disease burden, exploring the risk factors, and even more importantly, exploring specific interventions for prevention and control. Really critical. As you all know, next year, the NHLBI will be celebrating its 75th anniversary. And as part of that effort, we are refreshing our strategic vision. So I'm going to ask you, Alka, the question I would ask everyone attending. Obviously, you're not in a position to make recommendations to NIH or NHLBI, but what are your thoughts? What are the compelling scientific questions that still remain to be addressed? These data are very worrisome. So what are the critical challenges and the scientific questions we need to be addressing?
Yeah, thank you, George. I think there are two big data deserts. And this is true in India or in the South Asian region, as well as in diaspora countries and in the US. And I think they're at extremes. The big data desert is in omics data. We really have very little data in any South Asian population around the world. In fact, for all genomic studies that have been done in large consortia, South Asians make up, 0.5%. of the population, a really big difference compared to the global population of almost 25%. So we're missing the boat on looking at omics, and I don't think, again, the answer is going to be in the genes, but I do think that having genetic and other omics markers that are further downstream, like proteomics, metabolomics, will help us more precisely find people earlier in the stage where there may be ways to intervene with lifestyle behaviors, societal and other structural factors that make it easier to prevent the onset. So that is one big area that there needs to be more global investment. Then the other extreme is implementation studies. Your wheelhouse is there's not enough, and there needs to be more concerted effort in implementing things that work, but maybe work in a different framework. And I think that's really important, because the intervention studies that have been done are using more of a Western framework in thinking about prevention of disease. And I'm talking about the US experience, that we're using, lifestyle prevention that maybe other studies have used. And maybe we need to think a little bit more out of the box here and look at different ways to make, lifestyle changes or other changes that may be more relevant to those, the societal and the cultural ways of living. And I think that is something that requires a lot more investment and thought to see if we can start moving the needle.
Excellent. That's a very nice way to frame it. All the way from omics in fundamental discoveries to real-world implementation. That's precisely what we need to be doing. And I'm sure all of you will be pleased to know that the Transomics and Precision Medicine program, which we call TopMed, is another gem at NHLBI. Unlike many other databases, nearly half of the participants whose genomes have been sequenced are of non-European origin. So reflecting Masala, reflecting Mensah, reflecting the other populations we have. So it's a real opportunity.
George, there are no South Asian data in TopMed yet. We have applied to have Masala included. They're not yet included. So well, I will say there's zero South Asian representation in TopMed.
That sounds like where the future ought to be heading. These are some of the inputs that we really need to hear from you and from all the other extramural investigators, because we want to make sure that TopMed really captures the broad diversity of racial and ethnic and population groups. Srinath, let me bring you in here, because this has been a really terrific, rich discussion, but no discussion like this should end without mentioning Jeffrey Rose, because as you know, Jeffrey Rose taught us that when you have epidemics like what we've seen for cardiovascular disease in South Asia, you have to focus on the population approach. Not just the individual patient or the high-risk approach. So have we learned this lesson well when it comes to South Asia and the data that you're seeing? And what are the population level prevention and control strategies that are now in place in South Asian countries?
At least as far as India is concerned, at least as far as India is concerned, and even other South Asian countries, I think some of the actions started on tobacco control, with the Framework Convention on Tobacco Control being adopted in 2003. But diet was much more difficult to address, and physical activity perhaps even more so. So getting the population to really adopt and have the entire population distribution impacted by some of these has been a difficult task. But right now, recognizing the growing threat of cardiovascular disease, especially coronary heart disease, but also stroke, there has been a concerted effort in India now to address both through policies as well as through health systems. At the level of policies, definitely there has been a push for trying to promote healthier diets by emphasizing a reduction of salt in processed foods, in trying to advocate through Eat Right India movement adopted by the Food Standard and Safety Authority of India, trying to get people to reduce their salt, trans fat, saturated fat, and sugar intake, and also trying to get the manufacturers to try and reduce the content, and moving towards food labeling, which is also going to be telling the consumer what the levels are in this. Then there is also a movement to promote physical activity in India, recognizing again that this has been one of the weak points and possibly also contributing to insulin resistance. So these are some of the efforts. But at the same time, health system interventions are also necessary because far too long, non-communicable diseases, including cardiovascular disease, were left out of primary care. It was only addressing maternal and child health and a few infectious diseases. But now, through comprehensive primary health care, India wants to bring in NCDs very strongly into the focus, bringing in the detection of hypertension and diabetes in primary health care and the management of these also very strongly into the agenda of the health systems. And I think that's important because if you look at recent data from an ICMR study of 2017 to 18, there was a 28.5% prevalence of hypertension in people about 20 years of age. The more recent data actually are 33%. But the interesting part of it is only 12.6% of those noted were controlled. Yeah. So there is much work to be done. While we must certainly look at epigenomics, both environmental epigenomics, because air pollution is a big problem, and social epigenomics. And we must also definitely look at where the weaknesses in the health system are and try and address them. Because if we can catch pre-diabetes and raise blood pressure early on, we may be able to prevent much of this.
Yeah, that's excellent. This has really been a very rich dialogue, and we're running out of time. It's amazing how fast time flies when you're having fun. But let me ask all of you just very briefly as we close, and I'm going to begin with you, Alka, because Srinath's comments about primary care have relevance for all of us, and especially in the general internal medicine population. So any words of wisdom as we close that you want our audience to remember?
Yeah. With respect to, being a primary care physician myself, I think you have to start early in life. And that is the bottom line. Is some of our guidelines tell us not to screen until someone is 35 years of age for diabetes, not to screen cholesterol at an early age, not to start screening for blood pressure. I think that this needs to start in the pediatrics realm. And once people graduate to internal medicine, where I start seeing them in age 18, I do think we have to start moving to primordial prevention. And a lot of US data in other populations show how important this is, that if you don't start working early in life, you're going to end up with comorbidities starting in the 20s and 30s and 40s, and gestational diabetes, and just, making the cycle of diabetes even worse than it is now. So my goal is to really have primary care adopt this framework of primordial prevention and not waiting until someone is 50 to start implementing lifestyle changes.
That's wonderful. Primordial prevention, that's a word you don't often hear. We always begin with primary prevention and secondary prevention, but primordial prevention is crucial, as you just said. And some would even say we probably should begin at the preconception and making sure that the mother-to-be has outstanding care, preventive care, so that we give it the best opportunity. Chandra, let me turn to you. Words of wisdom as we close here.
No, this was a great discussion, and I completely agree that we can do all kinds of sophisticated things, but it ultimately comes down to populations adopting healthy lifestyles and modifying their risk factor. It has to start in the school-age children or their parents working with the school-age children. And there's a lot of good data now. If you do ultrasound imaging, you could show that plaque is starting in the femoral arteries in kids, right? So that is the time you have to do. And we have to get away from this primary, secondary prevention kind of a thought, because recently there have been papers that by the time you have an X amount of non-zero calcium, you're already into the risk ranges of people who have had an MI. So I think the primary and secondary prevention has done a disservice to us. And so we should start looking at, there's only one prevention, and that's prevention before the disease starts, right? Not after it starts. That's the first thing. And as a more practical issue for the middle-aged and the younger adults, we have to have a pool cohort equation like thing which is specific for South Asians, or some kind of a risk calculator, whether it includes biomarkers or not. Probably better to have some biomarkers, but we need a population-specific, resource-appropriate risk calculator, and that's crucial. Otherwise, we will end up saying it's too big a population to screen. What are we going to do? We need to have some guidelines to at least take the first steps.
Excellent, excellent. Srinath, I'll give you the last word, and it's one sentence and one sentence only. Words of wisdom as we close.
I think we need to ensure that even as we are trying to explore all the causal pathways from epigenetics to genomics everywhere, we ought to recognize that these shifts have occurred in a relatively short space of time, when there have been profound changes in the social environment. And we need to address those risks very strongly. And certainly primordial prevention, not only from the pediatric age group, but through effective policy interventions, which make it easy for people to adopt, to make and maintain healthy living choices across their lifespan.
Excellent. Make the right things the easiest things to do for everyone, and start early. And diets matter, and physical activity matters. This has been a really wonderful session. So thank you very much. And I'm going to ask the audience to join me in really thanking a wonderful panel for this rich dialogue this morning. Thank you very much.